We shall go on to our first speaker, Dr. ADITYA SETHI, who is again a senior consultant from Arunodaya Eye Hospital, Delhi. He's not just a cataract surgeon, but is also a pediatric and strabismus and a neuro-ophthalmology surgeon. And he is going to show us a very interesting cataract video. On to you, Dr. ADITYA.
Thank you so much, ma'am, and happy Diwali to everybody here again. It's an honor to be part of this webinar. I'll just start with my video. All right. Please let me know if you can hear the sound as well. And this is a truly happy Diwali sort of a case. I'm sure everybody will enjoy it. This is the story of 3 IOLs. Yes, in one patient. So this patient...
Could you bring down the music volume so that you are well heard?
Okay. Is it better? So this is a 38-year-old male wrestler by profession. Came with a traumatic cataract and mild zonal epithelial following blunt injury. So we did a nice cartwheel technique cataract surgery, placed a CTR because we found zonal epithelial at that region. And after that, we proceeded with the normal cataract surgery and placed the lens, checked for any...
Can you volume a little bit more, Dr. ADITYA, please?
So, so post-op day 1, he was 6'9". 2 years later, the same guy walks into my OPD and he says that whenever he lies down or whenever he's sitting, the vision is very different. And so this is what we found. We found out by talking to him that he's been coaching nowadays and he's now slowly leaving professional wrestling, and one of the punches resulted in this. So owing to the fact that there was a CTR there, I was pretty confident that it won't drop, but I still had my VR surgeon on standby. Went ahead and decided to do a ICC technique of removal of this IOL. So this is how we went. It didn't dilate also well, so we placed iris hooks. Made a sterile, corneosterile tunnel, opened up. Just with visco, raised the IOL, and with our iris claw lenses, I pulled the lens out in one total. And then the vitreous was swept back. We did a bit of vitrectomy. And in this situation, we were prepared to put an iris claw lens. So, slow removal of the iris hooks is done. In this moment, you don't want any vitreous following you, so a nice thorough anterior vitrectomy was done. Nicely making sure there's no vitreous tagging the CC. Another tip is to put Pilo and then use your iris claw forceps. And the iris claw lens was put in place. So keeping the count, this is the second IOL. And there, it looks beautiful. So we went ahead and did a visco wash. And our wrestler friend was doing much better. And we went ahead and this is how the vision was in post-op day 1. And then a few months back, he again walked into my OPD. Now every time he walks in, I'm a little scared. Now this time the iris claw is dangling, if you can see that. And not only that, the superior iris is also missing. So this guy had a trauma, another punch, and this time we suggested that after this surgery, please leave your profession or sit at a desk. And we ended up removing the iris claw and placing a Yamane IOL after doing a pupilloplasty as well. So now he's doing much better a month after. But the story of 3 IOLs is quite interesting. And a happy Diwali to everybody.
It was a very interesting video, Dr. ADITYA. So I'm going to ask Dr. Arun Jain. Dr. Arun Jain, you are there. Now, did this kind of I think you need to unmute yourself.
Yeah.
It normally traumatic zonular weaknesses are not a progressive one, but in this kind of case, primarily, would you have just placed a CTR or would you have done further? Is it necessary at all? I just want your thought on that.
Yeah, very nicely done case, but repeatedly he came back with some problem or the other. So maybe at the primary visit when there was some zonular dialysis, and as the CTR was in, I would have done a very simple technique like I would have made two Hoffman pockets and passed sort of hangback suture, two hangback suture with two straight 900 prolane that would have stabilized the IOL without producing much trauma to the eye, because removing whole lens with the bag, then putting a iris retrofixated IOL, then IOL again getting dislocated, then removing it again, putting a Yamane. So it's quite a bit of, I mean, every time we go in, we are producing some collateral damage inside the eye. So I have recently done 2-3 cases where one case is of dead bag syndrome, which I don't know whether everybody has heard of it or not. 20 years down the line, because of some reasons, the capsular bag blows out and there is a dislocation of lens within the bag. I had done this case, so it was a single piece lens. So in that case also, though there was no CTR ring, so within the bag, I did a hangback technique, which is one of the oldest technique of sort of fixing the IOL on two sides with two needles. I will show this video sometime. With two straight needle 900 prolane, I pass one needle in front, one needle behind the haptic within the bag, and pass it through the Hoffman pocket and tied it on both sides. So the day one patient had 6-9 weeks. So I would have done that.
Dr. Sanjay, is a message for us that if you have a subluxation, you never place a single piece IOL in the bag because of we put a 3-piece IOL, which itself could be more optimally utilized if there is a IOL bag complex dislocation. What are your thoughts on that?
See, I would say that if you have a subluxation in any quarter, and especially when it is traumatic, I would like to anchor the bag, because this could lead to problems later on. So what I would have personally done is that I would have put in hammer segment.
Okay.
And anchored the bag through a Hoffman's pouch at one side where there was maximum dislocation. And having anchored the bag, now you can put in any lens, even a single piece lens is not a problem at all. So that would have been the first approach. The second thing which was in this was that even though the iris claw lenses retrofixation are getting popular, but they have their own problems, because the iris gets atrophied at points and it subluxates, or the continuous movement causes macular edema. So that is a different problem altogether.
No, I wouldn't exactly pull down iris fixated lenses to that extent. I mean, I think if the primary surgery is well done, I think all of these lenses could do well. That another very important question which our audience would want to know is anybody who's doing iris fixated lens, how would we, Anaga, how would you think we can re-enclavate it, disenclavate it if you want? Like he has disenclavated and removed. It was in one place, it was enclavated
Actually,
one side.
Yeah, actually, I was about to say that first, when you put on one side the first place, I think the iris got torn a little bit. So I think it was already half only anchored on one side. On one side, it was well anchored, and the other side, maybe it was not so well. And because that iris got a little torn, already it was not very stable. So even with a mild trauma or even without a trauma also, it could have probably just, it was actually just decentered. It was not dislocated. If you saw this little arm, it was not totally dislocated, but it had just come down. So maybe it had come down already within a few weeks or months after the surgery. So when you want to enclave it again, then you just have to go back again upside the opposite side, and then you can do it. Many times when you're more aggressive, maybe probably that can cause the iris tissue is very, very delicate. So maybe that can actually cut through the iris tissue. One thing I wanted to ask you is, you put a CTR in the first place. Was there a subluxation at all?
There was a zonulopathy.
There was a subluxation.
Yes, correct. So ideally what is written in the books is, if it is more than 4 hours of subluxation, then you tie it with a Sionese or an IMED segment. Yes. Otherwise, a CTR should be good enough. And maybe in such cases, we need to counsel the patient to avoid such kind of contact sports, because
probably the contact
sports can continue to happen.
That was the problem for him.
Yeah,
that was a problem for him. Yes. Anybody, anything, Shalini, you want to add before we go on to our next speaker? And of course, one last question, which I do.
Yes, I think that was a very nicely demonstrated case. And I would agree on this take that whenever this zonular dialysis due to some trauma, there is a progressive fibrosis which might lead to this kind of situation. So I would prefer a kind of Sionese in such cases so that we can anchor the bag beforehand.
No, I would agree with you. I would say that if the traumatic dislocation is the only subluxation is the only time when you could be more aggressive. I mean, need not be so aggressive, because these are not going to progress unless the area of zonular weakness was more and a CTR was inadequate at that point of time. And in this particular case, the patient was into wrestling and those kind of sports, and probably, as Anagha said, it was not enclavated properly. If it was enclavated properly, it could have still been fine. So
trauma is a one-time event, no? And
it was a one-time event. So why should there be a progression? Exactly. Only in a progressive disease would you want to anchor it, or if the area of weakness is more, would you want to anchor it? Namrata, do you want to add anything before we go on to our next speaker?
This was a nicely managed case, but I agree with Dr. Arun Jain sir that I also would have probably done a Hoffman pocket rather than doing it like this. But having said this, I think it is also because I am not too well versed with the iris claw. We don't use iris claw lenses that very many. But I think because Aditya did use iris claw, so it was a good way of doing it.
Okay. Thank you. Thank you, Doctor.